A very good evening to one and all. Thank you so much for joining today's session. We are very sorry that we were able to only start the program 5 minutes late. Apologies for the delay. But thanks again for joining the day's session. So for the past few days, all of you have been listening to various aspects of infectious diseases management and antimicrobial stewardship from various experts in the field. So today we are going to talk about some out-of-the-box topics. So today is the last day of FCPI Virtual ID Week. And the theme for the day is non-clinical aspects of antimicrobial stewardship. So without any further delay, let me introduce the first speaker for the day. So our first speaker is Dr. Nitin Bansal. He's an ID physician at Rajiv Gandhi Cancer Institute, New Delhi, and a consultant at Indian Council for Medical Research for Antimicrobial Stewardship Program. He has been graduated from the prestigious Maulana Azad Medical College, and after that, he went on to complete his residency in internal medicine from University College of Medical Sciences and Guru Tej Bahadur Hospital at New Delhi. He has also completed his postdoctoral fellowship in ID from Apollo Hospital, Chennai. He has served as an observer in transplant infectious diseases at Wayne State University in Michigan, US. He has several national and international presentations and publications to his credit. A few of his accolades include, he stood first in the All India Pre-Medical Test in 2006, and he has been awarded gold medal by Dr. APJ Abdul Kalam in 2008. So the topic that he'll be discussing today is enhancing data management in antimicrobial stewardship. Over to you, sir.
Thank you, Vrinda, and thank you, organizers, for asking me to speak on this topic. I'll start by sharing my screen. I hope it is visible now.
Yes, sir. Please go ahead.
So I've been asked to speak on enhancing data management in antimicrobial stewardship. First of all, I must confess that I'm a clinician and I'm starting the session on non-clinical aspect of AMS. So I'm not sure how much justice I can do. Secondly, I was not that good in mathematics. That's why I took up medical biology and graduated with MBBS. So I'm not the expert in how should we design data management system. These are basically data management systems is a totally area of software engineers, but definitely in this era of collaboration, we need clinicians need to give their input and subsequently develop good softwares. So what I will do is that I will present some of the basics of an AMSP, what is the role of a pharmacist in an AMSP, and then I will move on to how should we be designing data management systems so that we can perform AMSP, study AMSP much better, particularly when considering Indian scenarios. So this is how antimicrobial stewardship is defined by various higher societies like SHIA, WHO, and ESCMID. What it basically means is that it requires a coordinated, systematic effort from various kinds of personnel available in the hospital, so that the appropriate use of antimicrobials can be defined, studied, and analyzed, and feedback can be given according to the clinicians. So, what is the role of a clinical pharmacist in AMSP or AMS programs? He or she actually is an integral member of this AMSP team, core member of the AMSP team. He or she advises clinicians for the right dose, duration, and route. Clinical pharmacist is an expert in interaction checkers. So they are supposed to be aware in this and keep on like giving feedback to the clinician that the drug A is interacting with drug B. They are again trained experts in drug metrics and how to analyze. I mean, it's one thing to do a matrix and then accordingly analyze and give some inputs. So the clinical pharmacist is a major role in drug metrics also. And then it all boils down to checking for appropriateness of the antibiotic prescribed. So this is what I thought is the role of clinical pharmacist in AMSP program. So what I said is I will try to give you certain basic examples of how to do antibiotic metrics, which is basically required from when a hospital in India hires a clinical pharmacist. Apart from doing interaction checks, advising clinicians on the right dose and drug, the main role of a clinical pharmacist currently in India is to do antibiotic metrics, that is the drug metrics. Currently, whatever I know is that most of the clinical pharmacists do not actually do clinical duties by doing, they are supposed to do like advising people on doses, drug interactions, etc. But that is their major role. So I will in the initial part of my presentation, I will describe the drug metrics, and then later on move on to data management systems. So antibiotic metrics are basically defined as there are many ways to study antibiotic consumptions. One of the most preferred method is DDD, that is defined daily doses, then the days of therapy. These are standardized methods and can be used to compare the inter-facility, inter-hospital comparisons. The other methods are length of therapy, prescribed daily dose, number of grams, number of tablets, and number of prescriptions. These are basically gross antibiotic consumption data. So in order to understand DDD, we need to understand the anatomical therapeutic chemical classification system proposed by WHO, which is known as ATC classification system. And as far as this other full forms have already elaborated. So when you go into the website of WHO and look into ATC category, from an AMSP program point of view, we generally try to study the systemic use of the drugs. We are not bothered about topical use of drugs. Or so in this classification, the J coding is basically used for all the anti-infectives who are for systemic use, and accordingly, according to the classes, they are subsequently subdivided into J01, J01C, and subsequently. And the exact details of the how they are classified and what are the code used need not be done, because this is already available on internet and can be easily accessible for free. So when you go into this URL, you will come on to this web page where you will get this type of window, and you can either use an ATC code, which again is not needed, or you can just put in your antibiotic name which you remember, or it's just like a Google table. It will prompt you subsequently. So you put the name, and then when you press the search button, the options will come. So just for example, I put a meropenem, so it will show two entries, meropenem and meropenem viborbactam. So just remember that in other examples, there may be other classification systems also, like A, B, C and all, but we have to stick to J, because J is the one which is for systemic use of antibiotics. So let's say I click on meropenem from here. So then it will give me the DDD of meropenem, which is 3. And also it will give the unit, which is in grams, and administrative route P means parenteral route. This is how it will go on. So how to study DDD of a meropenem? So this is a table which you can make in your Excel sheet, or maybe even in a register if you don't have access to Excel sheets. The month for which you are studying the DDD, formulation, IV or oral or inhalation, etc. What is the strength of the vial which you are taking, the number of vials which has been dispensed from the pharmacy, the total grams, WHO DDD, and the meropenem DDD for the patient. So I'll just give an example. For, let's say, for December 2021, we had 100 vials of 500 mg dispensed from our pharmacy, and 250 vials of 1000 mg dispensed, of 1 gram dispensed. So total grams you can calculate 50 grams in this first column and 35 grams in the second column. WHO DDD is 3. So Mero DDD is basically total amount of antibiotic meropenem dispensed, that is 50 plus 25 divided by the WHO DDD, that is 75 divided by 3, which equals to 25. So Mero DDD in my hospital in December 21 is 25. So generally, because we need to round it off, there will be more patients in some month, lesser patients in other months. So to rounding it off, we will use 100 patient days, typically 100 patient days. You can also use 1000 patient days or even more if the numbers are quite high for your hospital. So let's say in the month of December, which we are taking, WHO DDD was 25, sorry, Mero DDD was 25, and we had 700 patient days, so it will come out to be 25 divided by 700 into 1000 into 100, it is 3.57. This is the simple calculation of meropenem. Just to understand, we just taking another example which is slightly more complicated, because let's say colistin. So when you type colistin there, you will have this many options. Inhalational powder, that is the colistin is given parenterally as well as inhalationally also. So parenterally, the WHO DDD for colistin is 9. For inhalation, WHO DDD is 3. So again, I said this is going to be a little more complicated, a little more complex than the meropenem example. So in the month of December 21, total IV use of colistin was 450 million units, and total inhalational units were 25. So since that WHO DDD is different from all both the things, so we will calculate them differently. For IV, WHO DDD is 9, we just saw, and for inhalation, WHO DDD is 3. So again, it comes down to be 450 divided by 9, that is equal to 50, and 25 divided by 3, that is equal to 8.3. Now, we had 700 patient days in the month of December 21, so we'll calculate the colistin DDD, IV colistin use DDT per 100 patient days as 50, which has come from the table, divided by 700 from the patient days into 100, it is 7.14, and inhalation accordingly 8.3 divided by 700 into 100 is 1.18. So what are the advantage of using WHO's DDT formulation? So it is, first of all, it is obviously it is accepted internationally, and it is given by WHO. So everybody is aware about it. It is accessible, and you can like easily use it and measure the antibiotic consumption. Secondly, it is updated annually also. So if there is any change in WHO DDT, you will get to know. And it does not require patient level data. So from a bigger hospital or government hospital point of view, where you have thousands and 1,000 bedded hospital, 2,000 bedded hospital, it becomes very difficult to go bedside, each and every bedside, and to understand what is the antibiotic consumption going on. So it is updated annually. You can actually, just from the pharmacy dispensing accounts, you can actually calculate the DDT of your patient. So that is why DDT is basically commonly used in most of the antibiotic consumption data. But there are problems. It is not based on a standardized dose, and sometimes the prescribed dose is not what is actually WHO DDT. And the other issues, like when it is used for when there are pediatric cases in your hospital, then the DDT formulation does not take that into consideration. When there are renally impaired patients in your hospital, then again WHO DDT will be underestimated. So there are these issues with this formulation also. So it is generally advised that you take two methods of studying antibiotic consumption, because more patients of CKD might lead to a falsely low reportation of a particular antibiotic, because the number of vials will be prescribed lesser in patients who are CKD or on hemodialysis. So naturally, a second method will round it off. So second method, again, most commonly used is days of therapy. This is basically the number of days that a patient receives an antimicrobial agent, and dose of an antibiotic is received during a 24-hour period, represents 1 DOT. Again, very easy, the most simplistic form. This is one simple cefepime given on day 1 and day 2. DOT of cefepime is 2. Vancomycin given on day 1 and day 2. Vancomycin DOT is 2. This is as simple as this. So just to understand in a more elaborate example, let's say, for example, meropenem is given to a patient for 7 days at a dose of 1 gram IV thrice a day, and same patient also receives vancomycin for first 3 days at the dose of 1 gram twice daily. This is the Excel sheet. This is the table which I made. Meropenem given from day 1 to day 7. Vancomycin from day 1 to day 3. So what is step 2? DOT for that patient is 7 DOT for meropenem and 3 DOT for vancomycin. And now for DOT of 100 patients for meropenem, you need to know how much of meropenem was given in that month. So meropenem was given to 10 patients for 7 days. So my meropenem DOT is 70, and I will divide with the number of patients, like 200 patient days into 100, that is 300. 35, it will come out to be 35. So the DOT calculation is regardless of the dosing which the patient is getting. So it does not get affected. It can be very easily utilized in pediatric population also. Again, there are some disadvantages with DOT as well. First major issue is that it will require a patient level information. You have to go through each and every patient case file or case record, and then study the antibiotic consumption. Whereas DDT does not require patient level information. You can study directly from the pharmacy also. That is something which is very advantageous for DDT, but not for DOT. So I think everybody understands how to calculate patient days. This I need not go. Just accumulatively add all the number of patients in each day, and then you can get the number of patient days in a particular ward or a hospital of that month. These are the Excel sheets which you can prepare on your own, and basically calculate the DDT and DOT of any particular antibiotic. Formulas are very easy. You can just put it, and the Excel sheets will start calculating on their own. But the problem is that how to study, and the problem is not just simple antibiotic stewardship or studying antibiotic consumption, or basically understanding antibiotic prescriptions are not as simple as just studying DDT or DOT. There's a lot more complications. This is what I will try to emphasize in some coming slides. And antibiotic policies of the hospital can depend on whether they are for empirical antibiotic policy or targeted antibiotic policy. And most of the time, it is possible that we are not even after thorough investigation in state-of-the-art hospitals with all the investigations available, it may not be possible that we are able to make a good diagnosis of a patient. So how to go about that? So I'll just give a brief example. This is something which I saw in 2019. I was myself involved in the management of the case. 13-year-old boy who came from a rural area from eastern UP. He had undergone a stem cell transplant for thalassemia major, and 1 year ago, and he's been having chronic GVHD, and he's been on immunosuppression, cyclosporin. He has come to us now for last 5 days with no other localization, and he was given ceftriaxone at his local place. And since he was not improving, and he was our patient, post-transplant patient, so he came to our hospital. When we examined him, his vitals were stable. There was mild rise in respiratory rate of 30 per minute. He was febrile. His chest was clear. SpNS2 was normal. Per abdomen was okay. There was no major skin findings. His basic blood test, which we had done in the emergency, showed hemoglobin of 9.4, slightly high TLC with neutrophil leukocytosis, platelet count of 2.5 lakh, and mild transaminitis. X-ray chest was normal. So we made a syndromic diagnosis of acute undifferentiated febrile illness in an immunocompromised host. And we kept 3 possibilities at that time: malaria, scrub typhus, since he came from a rural background from Eastern UP, and a possibility of gram-negative sepsis as he was immunosuppressed. So he was started on piperacillin tazobactam plus azithromycin after sending appropriate test. So the question will always come: is this appropriate antibiotic to start in this kind of patient? We have a syndromic diagnosis, we have the possibility, we have all the details of the patient. Is it appropriate or not? As per our antibiotic policy of the hospital, it was appropriate. Empirical antibiotic therapy for acute undifferentiated febrile illness is piperacillin tazobactam plus azithromycin. Because we deal with immunocompromised hosts, so we generally start with BLBLI. We do not stick to just third generation cephalosporins because gram-negative infections are quite common in our hospital. So subsequently, his fever continued. He did not improve. There was mild increase in respiratory rate also. You can see the X-ray. There was bilateral infiltrate symmetrical. There was also mild drop in SpO2 when he went to the washroom, also up to 91%. Cultures were negative. Malaria, dengue was negative. Scrub typhus was awaited, and his procal was 5.8. Clinician at the bedside thought that since he's deteriorating and his procal is slightly high and cultures are negative, they decided that we will stop piptaz and azithromycin, and we will straight away switch to meropenem. Question again is whether these are appropriate antibiotics or not. Coming to subsequent stays, his stay in the hospital, in a day or two, he became altered and he got shifted to ICU. We had a suspicion of CNS infection. Meropenem dose was escalated to CNS doses. Vancomycin was added. Doxycycline was also added. We did a CT head, which was normal. We did a CSF, which basic report showed 50 TLC, sugar of 76, and slightly raised protein of 100. We did a state-of-the-art meningitis panel, very expensive, but it was negative. Gramshin was also negative. Now again, question will again come. We have again changed antibiotics, whether these are appropriate antibiotics or not. Subsequently, patient became better, fever came down, he became conscious, respiratory settled, SpO2 settled, and retrospectively, we found that his scrub typhus IgM was positive. So now from all the antibiotics were cut down and he was shifted to only IV doxycycline. So we made a final diagnosis of probable scrub typhus with encephalopathy and lung injury. And during this just 7 days of hospital stay, he received ceftriaxone, sulfactam, piperacillin tazobactam, azithromycin, doxycycline, meropenem, and vancomycin. Question will always come: in 7 days of this hospital stay, he received close to 7 antibiotics. Now, this is after we are working in a tertiary care center. We had an infectious disease physician on board, myself, and we had all the tests available. But still, we needed 7 different antibiotics to be given in 7 days of hospital stay. So antibiotic prescriptions are very difficult to understand, and antibiotic prescriptions can be either empiric, like we started him on day 1, can be targeted. Like when we de-escalated him to IV doxycycline, we made our diagnosis of scrub typhus and we switched from all the other antibiotics to doxycycline that was targeted. Or sometimes they are given as prophylaxis also. Sometimes this empirical antibiotic turn to be targeted after the culture report or some other investigations which prove your infection. But sometimes empirical antibiotics remain empiric. And this is not sometimes, this is actually happening most of the times, because we are not able to get a diagnosis of an infection. So empirical antibiotics remain empiric. Or sometimes empirical antibiotics are changed empirically because of some other patient-related factors like renal hepatic impairment. Like, for example, I started someone on colistin. Later on, we found that his creatinine was high. We didn't want colistin. We switched to some other agent. Or let's say I started the patient on vancomycin, on daptomycin, but I found that the patient is having pneumonia. So I didn't want my patient on daptomycin, as daptomycin does not work in pneumonia. So I switched to some other agent. So these things keep on happening on a daily basis when you see the patient. So nobody remains on a single, not every patient remains on a single antibiotic throughout his course of stay. Antibiotics are very quickly changed, and whether they are appropriate or not is always a matter of debate. So antibiotic prescription depends on the syndromic diagnosis which a clinician makes. And again, when a clinician makes means a different clinician can make a different clinical syndromic diagnosis as well. Antibiotic prescription depends on renal and hepatic function. They depend on age. They depend on penetration into the affected area, local antibiogram. Last culture results also sometimes also dictate the antibiotic prescription and current endemicity. Like let's say you're dealing with in the COVID era, if someone comes with fever, you're not going to give an antibiotic because it's most likely going to be COVID. Or someone comes when there is a huge wave of dengue going on in and around, then obviously empirical antibiotics may not be even needed because you know that it's going to be dengue. So current endemicity, also current awareness of the current situation also leads to change in the antibiotic prescriptions of a particular patient. So data management system which are capable to study these kinds of variables also are of utmost important, and this is something which we need to understand as a clinician, as well as we need to make the data management developers, system developers, to make to understand that we need to study all these factors in order to understand the antibiotic prescription. Simple Excel tools won't be enough. If you want to perform good AMSP in your hospital, you need to make more complicated and more sophisticated software systems to understand. So we need to take all these factors into account, which a clinician takes into account when he prescribes. So appropriateness of an antibiotic cannot be just decided on whether they are compliant to policy or not. They require many more efforts. So this is some of the examples, like syndromic, like a drop-down menu. We need to make a software where there is a drop-down menu. Syndromic diagnosis drop-down menu, and this is some of the examples where you can have huge list of syndromic diagnosis where you have almost 50. The clinician is free to choose from 50 of the options, and for what he's starting or prescribing an antibiotic from. And secondly, when you're changing an antibiotic, why are you changing an antibiotic? Whether it is persistent fever, deterioration, some CT result has shown, some hepatic dysfunction or renal dysfunction, you want to switch from IV to oral, or sometimes patient can get an allergic reaction due to some previous antibiotic. So all these factors need to be studied by giving you drop-down menu. This is something which we need to prepare when we prepare data management systems. Again, then we can definitely come on to whether it was guideline compliant or stewardship comment, whether it was appropriate or not. So this is what I'm trying to say. Antibiotic prescription is quite complicated. So in order to prepare good data management systems, we need to understand and prepare our data management systems accordingly, which takes the clinician, understands the clinician mindset and take that into account. This is something which I found recently, that in order to understand or study the de-escalation protocols, this is a paper which I studied recently, published way back in 2014, but they have basically given the spectrum score of various antibiotics which are available, and they decided their spectrum score based on the antibiotic spectrum, organisms of interest in their country, and the prevalence of resistance mechanism. And as you can see, even in this also, like say colistin is given lesser antibiotic spectrum score as compared to, let's say, tigecycline, or as compared to, let's say, even ticagrelor, clavulanic acid, or even piptazo, because colistin, although we think it is a higher end antibiotic, but it is of a lesser spectrum as compared to a BLBLI or a carbapenem. So this is something which can be utilized in our country. Probably we need to modify the spectrum score according to our needs. So in this study, and they found out that when they studied their antibiotic prescriptions as per the spectrum score, they found that there was broader use of antibiotic choices when the patients came in nights and in over weekends. So this is another factor which actually is true. When we see patients on a weekend or in the night, we tend to give broader spectrum antibiotic cover. So this is another factor which comes into mind when we write antibiotics for our patients. So studying antibiotic prescriptions is complex. This is my last slide. We need to enhance our data management systems which understand all these things and take into account various factors, and then probably comment on the appropriateness of antibiotic. I know this is complicated. Some sort of a collaborative efforts are required, but we need to embrace or emerge, or understand the problems, and then only solutions can emerge. Thank you. I think I finished on time.
Yes, sir. I think before time. Thank you so much, sir, for that very informative session. So we have a few questions for you. So the first question that we have is from Dr. Saili Gaur. She is asking how to interpret days of therapy and length of therapy per 100 bed days. Can we use the same principle as it is used to interpret DDD?
See, they are basically DDD is a different. That's what I was trying to say in the example also. The DDD is basically a pharmacy-driven data, whereas DOT and length of therapy is basically a patient bedside data. So yes, you can compare DOT from the previous month or from the different hospital if you have similar sort of an hospital. So for comparison, they are okay. But if you are doing DDT versus DOT, then obviously they are like comparing apples and oranges. So in order to analyze, what I'm trying to say is that what you mean to achieve by doing MSP is that you want to decrease the average DOT of a broad spectrum antibiotic and probably increase, or let's say even you want a static use or increase in the lesser spectrum antibiotic. For to give an example, let's say I want my average DOT of a meropenem to come down in my hospital, but at the same time I also think that by making the meropenem DOT lesser, the use of narrower spectrum antibiotic like let's say third generation cephalosporin or even first generation or anti-penicillin penicillin group of antibiotics, they will increase. So that is how we are supposed to study any DOT. Lesser DOT for a broader spectrum antibiotic and more DOT for a narrow spectrum antibiotic. That's how we are supposed to study DOT. But definitely can't compare DOT and DDT.
Thank you, sir. The next question that we have is from Dr. Shrikant, who says that I think we need to change 4.5 million international units to CBA to calculate the DDD of colistin. So what is your opinion on that, sir?
See, you can change it, but currently what I saw from WHO is they still give it to be in million units. So as long as they give in million units, we have to study in million units only. I understand that we have to, the better understanding is with CB only. But because DDT are calculated based on the denominator which WHO provides, so we have to stick to the same unit. We can't change the units. Since they are providing in million units, we have to give in million units only.
So the next question is there any systems in place for data management existing in the market?
We are trying to prepare, like I work with ICMR also, so we are trying to prepare. We have already made some of the hospitals which are, I mean, some of your audience may be part of that hospital system also, where we are already preparing it. And we keep on improving that system according to the feedback which we give. We learn something daily. But I'm not totally aware of any independent or private organization who had created a system. There are a few systems which I saw, like in Gangaram Hospital, we saw a system and a system where I worked earlier also. But after working for in so many other places, what I realized is that they still lack some of the points which I was trying to emphasize in my presentation that a clinician takes into account. So again, I mean, as a pharmacist, clinical pharmacist, or as an ID physician running an MSP program, at the end of the day, you are supposed to tell whether this antibiotic is appropriate or not. Yes. That is what it's meant for an MSP point of view. So we need to understand whether the system takes all these factors into account. The data has been entered in accordingly, then only we can decide whether they have been appropriate or not. Otherwise, we are not doing justice to the clinician by commenting on appropriate without understanding his mind.
Also, so when the topic of data matrices, antibiotic matrices or data management comes, I think the role of hospital IT is huge. So how do you think hospital IT can support antimicrobial stewardship in terms of data management?
This again, which I said earlier, this is not our area. This is software engineers area. Yeah. But problem is that we need to collaborate with them. Unless and until we collaborate with them, they can't understand what we are trying to say, and we can't understand what they are trying to say. I sit with the IT team of ICMR. They are not even biology graduates. They are obviously engineers. So they don't understand any of the terminology which we use commonly in our day-to-day practice. So in order to make them understand, sometimes you have to use simple mathematical logics which we studied in our school to make them understand. And we need their help. It's not like it's not like someone tries to say me that I will learn coding and I will start doing all these things. I mean, you can do that, but not everyone will be able to do that. And even if we learn coding, we will not be doing justice to the capability of the computer which we currently have. So we have huge potential. Our country has huge potential, and I think it is possible if we sit down together and understand each other. It is possible. I don't think it is such a big task to prepare a antibiotic stewardship management system.
So also another aspect of data management is data reporting. So I think equally important, in a collection of data is one aspect, and effectively reporting it to the clinician is also equally important. So from your experience, so you are an ID physician who's actively involved in antimicrobial stewardship programs. So from your experience, what do you think are some of the effective ways in which we can, the stewardship team can communicate the data that they collect to the clinical teams in the hospital?
I mean, I've been working in the cancer hospital for the last 4 years, and all I can say for my credit is that now people have started slowly understanding what I'm trying to say. So because they have their own practice, which has been going on for last 25 years, 30 years, and also suddenly if you expect that you will give them a new idea and they will understand it, it's not going to happen. So number one thing is that you have to be patient. That is something which I see personally. People are becoming impatient. So they don't take our advices. They don't follow our advices. So we can't give. So we have to be more patient. Secondly, what a clinician loves is someone comes at the bedside and then advises something. So that is something which an antimicrobial stewardship team should do, is that they should go to the bedside and then probably advise a clinician that this is not the right way, this is the way. And another thing is that when you advise something and if your advice is followed, then you should make sure that now it is your responsibility that the patient is fine. So you need to check on the patient another 24 hours, 48 hours, 72 hours, or even after discharge also, that the patient is fine or not, and then give the clinician feedback that we have followed and patient is fine. This is how you gain confidence of the clinician. So after you have gained confidence, then things become easy. They take your advices more seriously and then follow. But without going to the bedside, if you try to advise someone based on a culture report and all, then it becomes very superficial, and they generally will back off from your advices. This is what I have learned, and I would definitely recommend all whosoever they are, whether they are clinical microbiologist, clinical pharmacist, go to the bedside, see the patient, and then advise on GMSP activities.
Thank you so much, sir. I think that's all with the questions. Thanks a lot for accepting our invitation and joining today's discussion. Thank you, sir.
Thank you for having me. Thank you.
So we'll move on to the next speaker for the day. So our next speaker is Dr. Mohammad Hisham. He's a clinical pharmacist at Cleveland Clinic, Abu Dhabi, and also holds multiple adjunct faculty positions in international universities. He has earned his pharmacy degrees from India. He's an American board-certified pharmacist in critical care as well as infectious diseases. He's presented he has presented over various research papers and also has various publications in national and international journals to his credit, including a toxicology book. He has been invited to talk at various international and national research events, including a paper presentation in the ASHP Mid-Year 2019 in the US. He has won the Young Intensivist Award for Best Innovation Research Paper at the Criticare Conference in 2016. Apart from all that, as far as FCPI is considered, he's one of the founding members of FCPI, and he serves as a member of the board of directors. He's also the lead of FCPI infectious diseases. On a personal note, he's like a mentor to me, and I've had the opportunity to work with him on various research projects. So today he'll be discussing a very interesting topic with us. His topic is artificial intelligence and machine learning in infectious diseases. So without any further delay, over to you, Hisham.
Thank you so much, Shivanta, for the introduction. I'm trying to share my screen. Okay. I hope it's visible. So without wasting much time, next topic is something which is very interesting and very curious for multiple people, because it's something which is lying ahead in the future. So it's artificial intelligence, machine learning in infectious disease specifically. I do not have any disclosures. So this is a metrics world. A lot of data is there. So three participants will be attending this session. So three categories of participants. One who may be thinking artificial intelligence, something which is the future. Let's know and learn what this is all about. The second category of participants who may be attending this is artificial intelligence, which is coming up in the future, sci-fi. It may not be reality. It's just something which is there as a tale. And a third category of participant would be either of those. They may be thinking it's either of those, and just attend this session and see what makes it interesting. My job here is to take you from the time machine, put you inside the time machine and take you ahead in the future, months, years, or even days ahead and show you what's lying in the future and change your perspective of how you think about artificial intelligence, and just making you think more about how you can involve in these things and get it done better in the future. The learning objectives of today's session is basically to discuss applications of AI in clinical practice, ID, stewardship, practical applications of it, and even quality metrics of stewardship. So if you think about, is it really a reality which is going to come, or is it something which is going to come in future? I would take you way back when they found computers. Who might have thought that computers would be a reality way back in the 1950s when they found out? And these people who, if you see on the screen, the pictures on the screen, people are working with that computer. And was it a reality at that time? No. And on the screen, if you're wondering where the computer is, the whole room is the computer with the data storage space. So that's what makes you wonder from this computer where we are now. So if I take you way back, 1956, IBM Ramac. So the whole room with the data storage of 5 to 10 MB in the room, which weighs more than 10 tons, and a price of $3,200 per month to acquire this system. This is at that time in 1950s. $3,200 equivalent now would be almost like a $30,000 plus per month, and $10,000 per megabyte for acquiring this Ramac in 1956. A few years later, 1987, Cray 2 supercomputer, storage of 32 GB. Weight has come down from tons to kilos now. It's 2,500 kilos. The price has gone up when the size comes down and memory increases. It's $30 million now. And if you think about this, how things have changed, who might have even thought this would be a reality? And you might have even thought that this would be only restricted to countries which are like developed countries or something which is ahead of us. So no, it is possible. Computer is available everywhere now. And not only computer, I'll have to explain about this. Any phone, specifically this phone, if you look at it, you have 512 GB, 1 TB, 2 TB memory. It's not only a phone, a photo, it's a photograph. It's used for photography as well. Multiple uses along with this. And internet is also connected. So if you think about way in 1950s, where a computer was very difficult, they made it into laptops, desktops, and again, when a phone was not a reality, where you can also browse through the phone and use it as a computer, and it comes like this. So all these are just, if you think it's not possible, it's possible, it may take time, it's not reality, it's not truth, but it is reality. And what we're going to discuss is artificial intelligence. In this whole session, I'll be taking you through the future of how it could change the practice in healthcare, and also the challenges as well. So let's get to know what artificial intelligence is. It has three components. So three components. One is machine learning. So if you see, I've put the definitions for each of those. Machine learning is using big data to predict things or to answer questions. So big data needs a lot of database. So like the computers had storage space, tons of weight, and a lot of money. So all this needs a lot of resources, storage space, and money involved. So machine learning is one of the components in artificial intelligence, along with computer vision, which is using pattern recognition and deep learning to recognize what's in an image. And followed by natural language processing, which enables a computer to analyze, understand, and generate a human language. All these three put together, it's artificial intelligence. So do you think, artificial intelligence is there in healthcare, non-clinical, clinical, non-healthcare as well. But why in healthcare, it makes it more challenging is because patient complaints, labs, vital signs, imaging, radiology, clinical assessment, medications, so many aspects of it. Say, for example, if you use a banking software, artificial intelligence, and this banking software, you want to generate a PIN, wherever in the world, based on the technology, generating a PIN is easy because it just needs someone to follow the artificial intelligence steps and rules, and it does not depend upon a person. The problem is the same, but it may not have to depend. It's all banking, and it's all, if you when you compare it to healthcare and things, the what do you call it, differentials and the multiple things which is assigned to that is different and very less. But when it comes to healthcare, all of these components have to be integrated. Does not fit all these does not fit one patient, and all does not fit all these investigations and things does not fit same for all the patients, and also changes based on region. Again, banking may only change based on the region if they have more advanced and developed things. So I'm just giving an example of banking. It's not just banking, it's multiple other things, but all of these put together, there are multiple aspects which depends upon the patient and depending upon region, and multiple other things which makes putting AI or predictions challenging in healthcare. So what are the scope of AI in infectious disease, and what could be the potential outcome? These are the scope and the potential outcomes of AI. And if you look at it, it ranges from a whole lot of things which stewardship pharmacist or ID pharmacist or ID physician or microbiologist or someone who is into epidemiology, anyone does, it all fits into this AI. So how can it be made easier, or how can it be made faster, quicker? And when you acquire AI, will people lose their jobs? These may be the questions which may be coming around your mind. But if you look at this, all of these aspects are covered in AI, and it just makes things life easier, a lot faster. And now in this world of healthcare, especially infectious disease, you need to stay, bugs are ahead of us. Why I say ahead of us is in the sense they acquire resistance, try antibiotics are less in the pipeline. If when you try to find out one antibiotic, bugs become more smarter, they become resistant, and they plan things ahead of us in such a way that becomes resistant, and we are nowhere. So to be ahead in terms of treating, diagnostics, anything related to ID, to find out what the problem is, all these AI would help. So these are some of things which I've listed are potentially where the scope of AI lies, specifically in saving time, life, cost, multiple things. So this would be an interesting thing, which if it comes in future in different aspects would be really nice to know. So currently, what is the integration between a clinician and machine learning system? So you are thinking of something which is fully automated, something which is partially automated, something which has no automation. Green is the clinician, blue is a machine. So currently we are in somewhere like in 2 or 3, I would say, because current status, the clinical work is done by clinician, and like no automation is there. Sometimes it may be partial, where you have to go to a system and kind of understand and identify questions and ask the machines to answer some of your clinical questions, which makes it like it would be partial automation. Say a clinician asks a question to the machine answers the query, and you get that done. So it could be through an online calculator or scoring systems, or even something which could help you in the diagnostic part or understanding the problem. If you go on to the next level, 3, 4, in partial automation, a clinician analyzes the data and suggestions given by the machine. That is, a machine is made in such a way that it suggests diagnosis and therapeutic decisions to make. A clinician after that analyzes the data which has been given and the suggestions, and he decides whether to take it or not to take it. And if you go to 4, the automated decisions are complete. The machine monitors and the patient takes therapeutic decisions, and clinician validates the decisions. If you look full automation, there is no physician or clinician in it. It is machine that replaces the physician or clinician, and it is kind of, they do almost all the things to make it easier. May not be for the complicated cases, but definitely for simple cases. This is how you could integrate a clinician into machine learning. Different data analytics. If you look at different data analytics, it's classified into 4 mainly. Descriptive analytics, it's mainly summarize data, define observable pattern. Diagnostic analytics, it's mainly to understand what and why it has happened. Predictive analytics, it's mainly understand what is likely going to happen. That is more futuristic. Prescriptive analytics, it's more what should be done and what would be the suggested next steps in the future. So this is how data analytics is divided, and these are the different categories which are most commonly used. If you try to understand what machine learning models are, it could be classified into three. One is supervised, other one is unsupervised, and third one is reinforced learning. So supervised learning is training data is available, features, labels, new data has been stored, it's been put into an algorithm, and a predicted outcome and labeled outcome is same. It goes, if predicted outcome does not match labeled outcome based on algorithm, it's not gonna, it's again, it's been partially automated or like done by a supervision of a clinician along with the machine learning. The previous slide which I showed, which it correlates. If it's unsupervised, it's fully automated, you have a lot of data. So if you look at all these input data, it's a lot of data from the database based on which you create a rule or algorithmic process, and you cluster that into groups like a syndromic approach to an infectious disease. So a patient presents with a neck stiffness, headache, or like fever, it could be meningitis. So that you are clustering all these input data into getting from into an algorithm to put that into a picture where you could suggest this would be the picture. Similarly, I'm just giving an example of meningitis, but it's not only for diagnostic purpose. It could be used for each and every aspect of from the when the patient comes into treatment and patient goes home, and things like that, along with diagnostics. So the input data, so this database has to be really huge to have it unsupervised, and it needs to be more regional also for certain things, because this could be the limitation. And clustering that into groups and putting that in to make a decision for a machine, and that's when it becomes completely automated. Reinforced learning is when you have an environment where you do the learning, and algorithm processing happens, action is taken, and it goes back and comes back, and again the same environment in which you learn from mistakes, maximize the benefits and rewards which you get from machine learning, try to optimize it to make it even more smarter than how it is. And it's a continuous process where then you learn from mistakes. This is called reinforcement learning. So these are just the different types. So now let's get to reality. So I have few literatures and publications and some studies which have been done with what we have in the current AI, which again, as I've already mentioned, has its own limitations. Currently, limitations are more and than more of things which are easy, but let's look into the data which we have. So how ID, like AI ID, can go into diagnostics based on imaging. If you look at this, this is one of the studies in which they've looked into chest radiographs where AI was helping to based on algorithmic approach, where through a computer vision, AI was helping to detect COVID-19 cases. So if you look at it, like as I've already mentioned, from machine learning, put into samples, downsampling and machine, all those things where an imaging is cropped, they look into the X-ray, and if it has a COVID-19 like picture, they put that, group that into groups, cluster that into groups, and then they decide if it's possibly positive COVID or negative COVID patients. So these were the results and how the X-ray looked like. There were true positives, the X-rays on the top corner, and you have on the right side, you have true negatives, bottom you have false positives and false negatives. Again, it is not completely which you could acquire, but still the true positivity was relatively kind of good, but still there is a lot of data which needs to be given for input of data should be needed, and then only you could extract multiple things out of it. If you look for AI in microbiology, multiple things it could be used for, starting from gram staining reports, where you can use this technology based on, if you look at this, this is an example of gram staining, where you see gram-positive cocci in chains more suggestive of streptococci, gram-positive cocci in pairs and chains suggestive of enterococci, and things like that, where it could be used for gram staining to start off with microbiology. Something which is definitely going to be useful is microbiology, and AI is mostly the antibiotic susceptibility testing, where you have to look for the minimum inhibitory concentrations for antibiotic, where again, with a mobile application, you to measure the susceptibility of antibiotics with AI technology, and based on which you measure the MIC base and the disk which has been placed with the Petri dish and what antibiotic disk it is, and then you measure, adjust the time inhibition zones and measure what it is, and then the results could be sent into an expert system where it could be processed and looked into for more details, and this could be made a lot easier. I'm just talking about these could be reality in future, and these are again tried, and these are just examples. This is a very good article which has been published in NEJM last month, and it would be good if you could refer these articles as well. Now, coming on to AI and diagnostic stewardship, as I've already mentioned, natural language processing is when you interpret, understand a language and try to generate results out of that. So this is a physician notes put in, and this could be used if for diagnostic stewardship purpose or to look for something else. I'm just giving you an example of diagnostic stewardship. So if this from the notes, the computer picks up a few, understands the language and picks up a few things which says that this is like a UTI, where patient has dysuria, pelvic discomfort is there, fatigue is there for past 2 days, and this has been correlated to sending blood culture, urine culture. And also, if patient does not have any urinary symptoms, and this could go against computer automatically placing any orders for urine cultures and things like that, and asking the physicians to look for something else apart from urinary tract infection. So these are just examples. You feed this data or algorithms into a system where machine learning is there, and then you set automated created rules where you have each patient goes through this criteria. Based on the rules, computer decides whether it's urinary tract infection, if it's pneumonia, influenza, and also risk factors of patient having ESBL. All these come in, and you pull off these from the notes, which has been done through natural language processing of the computer of AI. Now, if you look into outcome measures and AI, it's most of the time we're more reactive than predictive or proactive. So if you look at this data system, which has been put by Walters Clover, it's Sentry 7 predictive C. diff infection risk score, where most of the times what happens, patient gets C. diff, you isolate, and then you treat C. diff. Why can't you do it proactively by feeding the risk scoring systems and identifying patients on admission and kind of isolating them so that it does not get transmitted, and appropriately trying to reduce the risk factors and trying to treat them at the earliest when you have those diagnostics ready and set to go. So if you look at this timeline, admission, infection, symptoms, testing, lab confirmation, we always lie on the isolation and treatment, which is more reactive patient management. So so if you look over here, predictive surveillance and being proactive helps you early detection, continuous monitoring, and being transparent with the clinical justification of why you chose to stop antibiotic and risk scores and things like that. So if you look at this risk scoring system, high risk patients are identified by the score threshold, like patients on antidiarrheal medications, laxatives. You kind of stop them, and then you don't have to unnecessarily order any C. diff test, because these comes under diagnostic stewardship. Patients on high-risk antibiotics or prolonged use of antibiotics, where you put them in the high-risk category as well. Patients on PPI, again, high risk of having C. diff. So these you categorize based on the risk score, and you try to predict this ahead rather than just being reactive. So days before of the onset, you kind of predict. You can see the x-axis, y-axis timeline in the hospital is x-axis. Y-axis is patients ranked based on how quickly infections have come. The red dots are how early, based on this risk model, the C. diff could be detected, and the blues are when, if this risk scoring system, detection system was in there, how late you could go and end up, and how reactively you could do it later. That was basically about that slide. Understanding antimicrobial usage through AI. So this also helps us to be more proactive ahead of time rather than more reactive. So data driven by stewardship, mostly measuring antimicrobial usage. If you look at, you can predict the carbapenem uses Usually what we do is we do the data and then we present it at the end of the month. This was the usage of last month's carbapenem or the last quarter, last year's data, and you try to improve the future. Why can't you do more proactively? Think our prescribing rates have been gone high for this month, or and the predictability is that at the end of this month or at the end of next month, physician would end up getting this. So you list out the top prescribers, as on this slide you see the blue lines, and the red dots are the ones which these prescribers could end up by getting like they could end up by prescribing unnecessary antibiotics or more based on the current pattern. And this could be analyzed and studied, and this could be discussed with physician to kind of reduce or rationalize the use of carbapenems or like any restricted class of antibiotics. This same data could be replicated based on department and like cardiovascular, DDI, oncology, and you can see who are the top prescribers, who are the top users. Based on that, you can go ahead and inform them based on the quarters and share the data with them, so that you could be more proactive rather than being reactive when the damage has already been done. So process improvement measures, you can still the same thing, where you can see adherence to guidelines, whether drug levels have done, if there is drug bug mismatch is there, positive C. diff, no active laxatives, like again, like reporting positive cultures within 72 hours, and MDRO reporting, and all these things you can see you could kind of address it, intervene it ahead of time rather than putting that later stage and being more reactive. If you come to AI surveillance, you have to give a lot of input based on feeding data on population demographics, real-time climate updates, country-wise health records, things like that. And the AI would help you give the output which helps you assess the risk, automated surveillance, and disease outbreak alerts as well. Just sharing an example of a health map which was used in the US. Just an example, during the COVID-19 for our outbreak mapping based on natural language processing. If you look at this, based on the natural language processing in the state of Washington in the US, you'll see the cases reported for COVID-19 through health map software, where the outbreak mapping was done based on how many individuals, based on natural language processing, a system identified. And this, so if you look at this, 3, 4, 1, and new 6, total of 14 patients in a state of Washington based on the reports on February 2020. It's just an example where it was tried out, and these could be help for surveillance in the future as well. Some benefits of AI and stewardship is, as I've mentioned, proactive notifications, inconsistencies, real-time corrective actions rather than reactive, detect overuse of restricted antibiotics sooner, detect significant trends, outbreaks, proactive individualized prescribing, feedback could be given. Like these are all measures where stewardship things could be process measures, outcome measures could be improved, reallocate resources to support activities which are needed to be done earlier, or like more resources are needed, IV to oral switch to minimize line days. And a future lies in antimicrobial resistance, patient outcome, dose optimization, ADR reporting, genomics. These are areas where AI could help in antibiotic decision making as well in future. I'm not going to go through this whole slide all over again, because I've already given the permission for the organizers to give you these slides. So you can have a look at scope of machine learning, infectious disease. What are the different aspects in which it could be utilized? These are a few examples. Also, you can use this reference to kind of brainstorm and think about ways in which this could be helping, or you could also think about ideas which could come up in the future. And again, the target data decisions interface, what are the interfaces, all these, what are the requirements for machine learning, where use CDSS is clinical decision support system, where you could do these together, and what are the requirements for each of these to put and make it more successful. This is basically how you, what are the requirements and how do you put that in, and you can use this reference for knowing more about it. As I've already mentioned, there's nothing which comes without challenges. Global challenges are definitely there, not only for machine learning, AI, CDSS, or anything else. Definitely it's there. So what are the challenges in AI or machine learning is like definitely data. You need data. It's just not some 1 or 2 patients. You need a lot of data. Quantity and quality of data matters. Comprehensiveness. That really matters a lot as well. Availability, whether it's available in each region or not, like would it get to the regions or international global data would be available or not. Equity, adaptability, interpredictability, security of the data, validation, who validates this, confidence of how an automated system and you can go ahead with the decision made by the computer saying that it's going to be right, evaluating it, making it accountable, the cost which comes along with this, privacy, confidentiality, independence, unexpected consequences which would come. You have to learn from that, implementation and sustaining this. So all these are the challenges. So if you look at each stages, I just have some studies which have come out. This is a couple of years back in 2021 JAMA, an article where external validation of widely implemented proprietary sepsis prediction model in hospitals, it failed, where it showed that like it didn't have poor performance races based on fundamental concerns on sepsis management national level, where this predictive model did not help much for understanding sepsis in these patients. This is something which is very recent. I think last month this was published, ChatGPT versus ID consultation. So something which is very interesting here is they looked into, they fed that data for 40 patients who had who had bloodstream infections and thinking of infective endocarditis, and they looked into, they fed that data into ChatGPT and took the advice from ChatGPT, and they also got an advice from ID consultation, and they looked whether these matched or what is the percentage it matched. If you look at the number wise, mean complexity of consultation scores were 3 for the ID consults, and it was 2.8 for the ChatGPT outcomes. But if you dig into more into details, there were a lot of mistakes in this. So you can't, so the point I want to make here is not that AI is making mistakes, that this is just an initial stage. Someone made an attempt to do this paper and they've taken an effort to do this, and you learn from your mistakes, and a lot of mistakes would happen as AI comes in any field, not only healthcare, not only ID, could be anywhere. But you learn from those mistakes, and that's how you kind of build up your system or database in such a way that's useful for the future. See, that's why I shared the example of the computer in the beginning. It was huge. A lot of mistakes might have made, but now you have the computer in your hand as a phone. So think about how much it happened and think about the cost it had to occur at that time. And now the cost is cheaper for things like this. When compared to the initial phase, if you think that could only be done in developed countries, you are wrong, because this could happen in lower income countries or middle income countries as well. And resources needed, it's all, people can afford this, people can afford to do research on this as research intents to make it even better. That is all possible. And did people lose their job after computers came? No, they had more opportunities. So if you ask me, will AI, will you lose your job? I would say no. If AI and ID, you have to integrate both. You need a person who has an ID experience, a pharmacist or a clinician, microbiologist, epidemiologist, who can and then only AI can be functional. So you may have in the future, you may have clinicians, pharmacists, microbiologists, or epidemiologists who may be having an extra certification or training in AI to implement that. So if you look at this study had mistakes in that, where already labs, blood cultures and imaging were all done before, but still the AI suggested to do additional imaging and cultures and labs, which does not make sense. But this is something which is in the pipeline. It's something which is coming in the future, which will definitely come. And it is something which you need more data on. With what they had, they did this on 40 patients, and the numbers 2.8 and 3 is really good. But if you look into more details of this, there were a lot of mistakes which ChatGPT had made, and where it didn't match. But for some certain limit of patients, it also matched what an ID consult recommended. So a simple example, I would say, on reality, say for example, when you implement AI currently, in a state where AI cameras were implemented, there you initially it's for the good for the people of the region. So if you think about if there are a lot of mistakes being made, plus there's a lot of goods being done. So if you think about the number of probability of having a mistake compared to the reasonably good outcomes out of this, the outcomes are more when compared to results. And these mistakes could be through reinforcement learning, it could be improved and done better. Mistakes mistakes would happen in any of these, but that is something which would happen as an improvement process, and this could be incorporated as an improvement process and made it even simpler and better, faster in the future. So this is the present healthcare, public health, contact tracing, all these being done. You have to look into literature, data, trials, and outcomes, side effect monitoring, retrieve the patient's medical information, their complaints, and look into more decision support systems, searching the internet, imaging, labs, all those things, operational, like billing the patient, follow-up, scheduling, operating room, emergency department, ICU, ventilation, multiple things. But think about the future where a physician talks to the patient and the computer is listening. Everything is processed from the time of admission to discharge or in between, or if and this is kind of real-time scenario where this would come in the future. So with that, I would like to end my talk with the take-home message that AI can improve clinical practice, ID, and stewardship. It helps in clinical decision support systems, which would augment the clinical practice and application as well. So it may not make you lose jobs, cost, all these things are factor which is in the beginning, but as it progresses, definitely is going to be useful in the long run. And thank you so much. I hope this was something which I could take you a time machine way ahead. And now I would want you to come back to reality. And it's back to 2023, June 3rd on a Friday evening. Thank you so much.
Thank you, Hisham, for that very informative session. I think in the era of Chat GPT, it is very essential that we know how we can use these tools to better infectious diseases management and antimicrobial stewardship. So we have a few questions for you. So you have already discussed about the advantages, disadvantages, various publications on evidences on how AI and machine learning is being incorporated. So I think the biggest question is, how feasible do you think is AI and machine learning in ID or stewardship in a country like India, in a lower middle income country like India?
So as I've already mentioned, I can, as an example, as you mentioned, is it feasible in India or not? So do people in India have computer now? Do they have iPhone? Do they have a laptop? Do they have a desktop? We're having this webinar. People in India, low income countries, anywhere in the world, they definitely have this. If you ask me, was it affordable when it started? No, definitely not. But it is. So we are we can make it more affordable. We can make it more as things get a lot easier, and it would happen definitely in the future. So if you think about the initial cost, definitely everything what you acquire now would have an initial cost on it, but that should not pull us back from doing something which would be smarter and better. So all these computers are made by man. AI is also made by man. It's making the machine smarter through human intelligence. And still, the person who's intelligent is the human who created that. So it's the human mind in that. So if you ask me, is it possible in low middle income country or a low income country? Definitely yes, because everyone uses mobile phones now. Everyone uses laptops and computers. So I'm thinking more futuristically. For sure, it may come initially in the developed countries, but on long run, for sure, any low income, middle income country would have this as well, because it's progress for any country, as well as affordability as well.
So another question is that in India, especially, there are, I think, many of the hospitals currently have some form of hospital information system. So how do you think AI or machine learning, or how feasible do you think is incorporating AI into the existing HIS systems in the hospitals?
Yeah, so this is an interesting question. So you should not mix up electronic medical records decision support system with AI. So electronic medical records is something which is really good. It helps us for clinical decision support systems as well. And what on a long run, so this is something which you give input, you get it back to like, as I've mentioned, partial automation, which is in the beginning. So as you proceed, you want the system to interpret all those and give it back to you. That is AI. That is machine learning. How that comes is through data. So again, it's something which is related to the hospital or the region or a state or the country. You need that much of data. So if you think about patients in the hospital, you can't diagnose a disease based on the patient's data for that hospital, because that is too less. when you compare. But when you want something which is particularly related to the hospital, which all physicians, what all could be the thing, that data could be used to do it better for the patient, or risk of infection, things like that. That would pertain to that hospital only. But if you're thinking of a bigger picture and diagnostics and all, then you have to think beyond a setting in a hospital, in one hospital, go on multi centers, multiple hospitals in this region or in the state or in the country. Say, for example, dengue fever, or say a tropical infection which is related to a country, an outbreak which is there in a region. So you feed that in, that is a database. But if you think of something which is very common, like urinary tract infection, the hospital data would be very less when you think of a big data in AI. That would be a drop in an ocean, which when you compare about the regional or the state-wise or nation-wise data. That again, possibilities of getting mistakes are more on that rather than being more narrow. But you'll have to think what on that data, particularly which is limited to the hospital, can you pull off those things? Then it would be useful, rather than thinking of something which is very common and it's there throughout. You can't use that data because you need a lot of database for that. That may not be available in that hospital, but if you look country-wise, it may be available. But again, everyone has to think about it.
And I think the last question that we have here is, you already discussed about publications that we can refer to in your slides, but are you aware about any other resources for learning more about AI and machine learning in our specialty, like infectious diseases and stewardship?
So currently, this is something which is really new and more futuristic. That's why I told you I've taken you time machine ahead of time. So AI as such in healthcare, it's coming up. So infectious disease particularly, these were the things which have been done. So if you ask me, is there anything particular? There's nothing available. So you'll have to brainstorm, think, and again, health informatics would definitely help. Health informatics would help you to incorporate these. That would be something which is learning along with this. But all these, to have AI separately into ID, it may take time, but definitely it's future. And you should not be losing hope, because this is the future which is going to come up. And for sure, all those certifications, trainings, and things would come in the future, where particularly a pharmacist may also have an input or role to play in these AI certifications. So it would be an additional qualification or an additional degree, because think about an IT guy can't come and diagnose or put that, give that input which an ID physician or ID pharmacist or microbiologist, epidemiologist gives. So it needs a person who's already trained in that particular healthcare thing, or like ID or stewardship, to also learn about healthcare informatics or AI. So that is what would help them. That is the future.
Thank you so much. I think that's it with the questions. Thanks a lot for joining us for this session. Thank you.
Thank you.
So let's move on to the last speaker for the day. Right. So the last speaker for the day is Candice Bonaconsa. She's a researcher, nurse researcher, and PhD candidate at University of Cape Town in South Africa. She's currently doing her PhD that's focused on applying novel qualitative approaches to study communication and its impact on team dynamics in relation to infection-related decision-making. She has completed her master's in nursing from University of Cape Town. She has various national and international presentations and publications to her credit. And she has a keen interest in understanding the nurse's role in antimicrobial resistance within the context of wider multidisciplinary team. So to add on to that, I have experience, I have very close working relation with Candice, and we have been fortunate to work together on a international research project for more than 5 years now, if I'm correct. And Candice's work has always amazed me, and it's very interesting to look at how she has collected the data and the recommendations and the findings that she delivers as part of her work. So I think without any further delay, I'll hand over the stage to Candice. So today she'll be discussing about whether communication has a role to play in antimicrobial stewardship. So over to you, Candice.
Thank you, Verinda. I'm just going to share my screen. Great. Okay, that's done. Brilliant. Is it all good, Verinda?
Yes, please go ahead.
Okay, great. Good evening, everybody, and I just want to thank you, Verinda, and your team for this incredible opportunity to share with you tonight. So today I'm going to be speaking about the importance and the role of communication in antimicrobial stewardship. And really, I'm just going to be sharing some of what we've learned as we've done research looking at this in our local hospital through research specifically looking at communication and team dynamics. So I've got nothing to declare. So just to put in context that I'm a researcher from the University of Cape Town, and I work in the Division of Infectious Diseases and HIV Medicine. And I have a background in clinical nursing, as Verinda said. I'm based at a large tertiary hospital in Cape Town, and I really think that it's important, just for the benefit of this talk, to highlight the existing resources to support antimicrobial stewardship and IPC at our local hospital. So I think that this audience is very familiar with the burden of AMR, and there's so many quantitative outputs that have been conducted across the globe that have given us some insight into the size and extent of the problem of AMR. However, more recently, publications, especially led by Dr. Esmita Chirani and colleagues, have kind of used social science methods to shift insights into understanding more of the contextual, behavioral, and cultural factors that influence antibiotic prescribing behaviors and infection management. And so, as Verinda said, 4 to 5 years ago, we were recruited onto the ASPIRE study, which was a multinational study which was started in the UK, but then also extended to South Africa and India. And this is where we met with our Indian colleagues and had a wonderful time working together. But a lot of our data collection was looking at surgical teams, and we spent a lot of time observing surgical ward rounds. And it was here that I started noticing subtle differences in how people gathered around a bed space. Now, I mean, most of you, I think, are pharmacists, and I just want to think as we go through this talk of your role in the context of you contributing into ward round spaces specifically. But so as we were watching the ward rounds to gather data around antibiotic prescribing practices and infection discussions, we started noticing differences in how the team sort of gathered, mostly dependent on who was there. So for some consultants, you would find a very engaged group of people standing close around, the patient bed space. I suppose it depends on how you run your ward rounds. But then for other consultants specifically, you would see people standing further back, and the level of contribution was slightly different. And so this really sparked for me an interest around team dynamics and communication, and this is something that I have taken on to do my PhD on. So a lot of my talk is going to be around this. So really, this is the outline of my presentation. I'm not going to go into this, but just so that you can have a quick look where we're going to be going with today. But I think with this audience, you are very familiar that the WHO has declared AMR as one of the top 10 global health threats facing humanity. And from the Graham report, we know that AMR is a leading cause of death, particularly in poorer countries. I mean, we're also very aware of the key strategies. So we've been through this before, but really now more than ever, the strength of an effective antimicrobial stewardship can only be fully leveraged with a multidisciplinary team approach. And so while AIM, S, and IPC are specialized fields, and they do require a lot of specialist input, which happen on ID consult rounds or AMS rounds, but I'm going to move a little bit more intentionally to focus on communication that happens between patient-facing healthcare workers who provide patient care, such as pharmacists at the bedside, nurses, as well as doctors. And so here aspects and principles of IPC and stewardship are key and should be included in our routine discussion. So I just want you to take yourself there and think about what that would look like in your context. Are you having AMS discussions on normal ward rounds, and what would those look like? So effective communication has got a profound impact on the patient experience of care as well as patient outcomes. We know that. And research has well demonstrated that poor communication is one of the main underlying causes to diagnostic errors. And therefore, effective communication is a key tenet to patient safety. I think what's really interesting is that of the 50% of the adverse events related to communication actually happen on ward rounds. So ward rounds are really interesting because they happen, they're daily events. And I'm sure those of you who are a part of it are not even aware of what happens on that ward round because they are so routine. And so a lot of what happens in plain sight. And there are a lot of complex, sorry, there's a hooter outside here, if you can hear it. Sorry, coming from Cape Town, a loud hooter from our streets. So anyways, back to focus. So really what we are trying to do is to try and make these practices visible to our healthcare workers. So there really are a lot of barriers to interprofessional communication, and maybe you can think about what those would be. What are the barriers that you've experienced within the context of working with your colleagues? I mean, they can be quite complicated because a lot of it's historically entrenched in our professional hierarchies and silos, and the cultural and structural barriers that are found within our healthcare systems. And so all of these really have got an impact on how we communicate with each other at the bedside. And what's really interesting is communication itself is not the issue. But it's merely an expression of many underlying factors. And yeah, as I say, maybe just to think about what that would look like in your context. So who's responsible for antimicrobial stewardship in IPC? So this infection management and antibiotic decision-making really requires a lot of overlapping input and responsibility from many healthcare workers. So this was an output from our SPI study, but down the middle, you can just see all the different jobs in AMS. And on the left hand and the right hand side, you can see the teams that are involved in the care. But I think what's really interesting is that a lot of healthcare workers don't explicitly understand their roles in AMS and in stewardship. And so they don't think of the implications of their care in the bigger picture of antimicrobial resistance. So Verinda and I recently did this paper, which was really interesting, and we published a paper on the narratives from a global audience to answer the question of what does antimicrobial stewardship look like where you are. And I mean, if we had to sit with each of you, I wonder what some of the things are that you would say. So we got learners to engage after a MOOC course. We had many countries represented, 114 countries, and most of the participants were healthcare workers. So here are some of the challenges that were expressed. This kind of captures all the challenges across the process systems challenges, as well as challenges that participants experienced within their own healthcare teams. But interesting was that, and maybe you won't think that this is unusual, was that AMS and IPC teams work in silos, and there's a real underutilization of pharmacists and nurses in stewardship. So the WHO was also recently running a support to really support national action plans, and they were looking at the role of the bedside nurse in stewardship. And here the Chief Nursing Officer, Elizabeth Ira, comments on the importance of the nurse role. And she stresses that the nursing workforce is key, in addition to nurse-specific recommendations, emphasizes that every infection prevented is one that needs no treatment. And so there's so many hands that are needed on deck to prevent infections. And so an extremely useful scoping review came out of South Africa, which was also really looking at publications to try and emphasize or highlight how much the bedside nurse role has been included in stewardship recommendations. And I really just want to shoot straight to the right here. Out of all the articles that they chose, they selected, they found that in 72 of these pieces, the team composition of stewardship teams was described, but the nurse role was only included in 32%. And of this, there was very little reference to the bedside nurse. So it's interesting, really, when we look at, team dynamics and the exclusion of some voices. And I don't know in your context whether nurses are less included, and whether that would be true for pharmacists as well, especially when we're looking at infection care. But I recently have done a scoping review, and really what I was trying to do was to try and get from the literature mechanisms for effective communication, specifically to apply to infection care discussions at the bedside. You can see that we included 53 articles. All of the information is coming from high acuity settings. Half of it's coming from high acuity settings, but no publication from LMIC. So we've really got a big gap to cover. But it was really interesting when one looks at effective mechanisms for communication. There were two things that stood out. The first was the strength of when we standardize and facilitate collaborative healthcare input into patient care and the benefits of that. So that's really making mandatory input a part of every normal round. So there's a space for the doctors to speak, there's a space for the nurses to bring their contribution. So it's an expected contribution that's brought. And secondly, the importance of structuring and standardizing approaches to communication, especially to ameliorate the barriers to effective communication. The hierarchies and the different sort of influences that we see when not everybody is on the same level. So next, I'd just like to touch on some of what we found in our local setting through the research that we did. And the first is really to touch on findings from the ASPIRE study, which we did in South Africa and in India and also in the UK. And just to reiterate that we were trying to understand factors and behaviors that influence antibiotic prescribing decisions in surgical teams. So we looked at our GI wards as well as cardiac and thoracic ICUs. And what we noticed was what I said right at the beginning of the talk, was that in some instances, the team dynamics would shift related to who was there. So we started off by doing ethnographic observations, which is really in-depth observations on what people are talking about, what exactly is happening on the ward round dynamic, but then specifically looking at decisions around antibiotic prescribing and infection care discussions. But then we also decided to include something called a sociogram, and I'd just like to take a little bit of time to describe this. This was this became one of our key data collection methods. But I just first want to tell you what a sociogram is. Generally, sociograms have been used to represent different social links, relationships, and hierarchies in a group situation. But what we wanted to do was we wanted to capture communication around the bed space by the role players. And we were trying to get to a place where we could visualize communication, but also quantify it. So we applied this to the ward round, and really just to show you what a sociogram is made up of. It's captured using specific icons for each different category. So we would have categories for our doctors, icons for our doctors, icons for our nurses, pharmacists. So you could actually map this out and then also see who was participating in the round. But importantly, we were trying to capture content and direction of communication. So on the left-hand side is an example, On the left-hand side is an example of a ward round discussion of one patient handover. And what you can see, what we were able to do here is we're able to capture where our role players are, all our different healthcare workers, but particularly we were looking at infection care discussions. So we developed a set of themes that related to specific colors by which we were able to capture the discussion as they happened. So here we can see where people are standing, we can see who's talking, and we can also see who is talking about what. So this becomes a very powerful tool then to feed back to the teams so that we can show them what their communication looks like. So this was one of the main outcomes from the ASPIRE study, and this is a sunburst chart on the right-hand side. It looks a little bit complicated, but the inner circle shows us who is talking to who, which is in the next circle, and about what, and those are the sort of the colors on the outside. But what we found from our ward round discussions was that most of the communication happened between consultants and registrars. We found that other healthcare workers were not engaged that much, and especially nurses who have an active role in infection management. So what was interesting here is this was the cardiac and thoracic ICU, which pharmacists did not attend, and that's why we don't have any specific data on them. But here I just want to show you the colors down at the bottom here. This represents the infection care discussions that we had. And then it's also interesting to see, how very little nurses are spoken to on our ward rounds. And this was specifically nurses were spoken to on related to lines and invasive devices. So there's no initiated contribution from nurses on our rounds. So what was interesting here was that we noticed about the nurses on the round that they're not expected to make a contribution. So now we're thinking of why is communication, why is it important for us to think about communication in the context of AMS? So nurses who have a role in stewardship were not expected to make a contribution. Interesting is that they positioned themselves on the outside of the group. We would often find that they were there and not really engaged. Any new plans around infection and infection management and antibiotics, interestingly, was mostly communicated to the registrars and very seldom directly to the nurses. So we also saw that there were quite a lot of key inconsistencies in how infection-related discussions happened in the context of other priorities with the patient. So again, the question back to you is, what do these discussions look like on your ward rounds? And most importantly, we realized that leadership styles impacted on who was engaged in the specific ward round discussions. So we fed this information back to our teams, and they were really interested, especially in the sociograms and what was being highlighted around team dynamics. And so we were invited back, which was really the start of my PhD, to look more into team dynamics and communication, specifically now looking at critical care teams. So I'm just going to share a little bit about what happened from that point on. We were very privileged to be able to improve our sociogram, our visual mapping tool. Was what we realized was the one on the left-hand side was the initial tool that we used. And although it gives you a graphic picture of what's going on, it was very difficult to capture the sequence of communication. So we improved the tool, but then also importantly, we started seeing that there were other dynamics on these ward rounds that impacted on the message. And the first was people having parallel conversations, as you know, while the ward round was busy happening, and then also people accessing their smartphones. So those were some of the things that we started including. So this is really just a sort of an output of the data that was collected on the rounds, and I did ethnographic observations, which then helped to inform a framework for the sociograms. And I'm not going to go much into this. So when we're looking at our sort of communication pathway in the ICUs, and maybe think of what these communication pathways would look like on your rounds that you attend, and we just needed a framework by which to capture the information, and this really followed the patterns of how our teams communicated. There was information accumulation where the registrar gave an update, then everybody would lean in and there would be a discussion of sense making, and then generally decision making happened after that. So in our updates that the registrars provided, they always provided a standard section on IPC and AMS routinely, which included infection biomarkers, culture results, antibiotics, as well as invasive devices. So this was a standard update which was included in every single ward round. And it was also interesting that although the registrar gave that update, the consultant facilitation style really determined the flow of how the rest of the ward round would go. So now looking at participants in our rounds, this is, we're looking at communication. So I'm looking here at the contributions by different role players who attend our ward rounds. So here we can see in our context that the contributions of pharmacists and nurses are very low in comparison to the registrar and the consultant who do most of the talking. And you might say, but you know what, not everybody needs to speak, but it's important that we look at this and think about what the implications of this might be. So this is looks like quite a busy picture, but here I want you to see who initiates communication on the left-hand side, and along the top is who they're speaking to. And again, you can see a lot of the communication is happening between consultants and registrars and generally to the group. And here we can see that nurses again and pharmacists are not doing a lot of the contributing. What we were able to take from our data was looking at the ratio of the kinds of contributions. So you want to see, do people speak out? Do they make a statement and add information, or do they question a lot, or is a lot of the contribution a verbal response, so because they were asked a question? So here we can see that the pharmacists, they brought contributions, whereas the nurses mostly responded through answering either a question or a statement that was directed at them. Again, in our context, we've had to say, should nurses and pharmacists be contributing more? Do we want to see a shift in these ratios? So really, this is just to touch on, what our teams were talking about. When we added up all the sociograms, we can see that there's a consistent, almost half of the communication is the registrar's update, but then there's a fair amount of communication on infection, diagnostics, and IPC. But what I also want to highlight here is the aspect of direction of care. So this is when a decision is made. I want you to think about what that looks like in your context on your rounds. When a decision is made and communicated with the team, we found that there were two things that really affected how that message was taken up by the person who would action it. So, for example, the nurses and the registrar stand there, and as the decision or the instruction gets delivered, they write it down. So that was for me a measure of uptake, was acknowledging and writing it down. So there were two things that affected the uptake. The first was the manner and the direction of information. So the manner, sorry, let me start off with the manner first. The manner is how you deliver the instruction or the plan, and that is whether it's assertive and you say, I want this and this and this done, or can we do this, or was it done in a suggestive manner, which is, and this is often personality styles, where they'll say, I think we should maybe consider doing a echo later today. And you can see that at that point, those junior doctors as well as the nurses are not quite sure whether that is something that they need to put in place or whether it's something that, might become implemented later on. So important for you to think about in your own context as well is the manner in which plans and decisions are communicated, as well as the direction. So the direction, this was really interesting to see whether when a decision is made, whether the person looks directly at the person who needs to activate it. So, for example, if it's a nurse role, or a nurse action, that the consultant would look through the group, find the nurse and say, can you please do this or carry out this? So really interesting was assertive directed communication. The uptake was 100%. And in suggestive undirected communication, there was no uptake, as in acknowledged and written down in 90%, 96% of the cases. So that's quite profound. Just looking at nurses, and forgive me for going into sort of a nurse process, and it's just because that's particularly what I was looking at, but I wanted to share something interesting. So the first was that, nurses were not really engaged in the ward rounds, but then they also, they asked me whether I could help them as a result of this project to look at their handover process, their nursing handover process, so not the multidisciplinary team process. And so I just want to quickly go through a very exciting project that we've been busy with to redesign a nurse prompt handover through a collaborative process. So the nurses said that they wanted to relook at their handover, and they wanted a prompting sheet, a map. So firstly, to try and get them to think around the topic, we did a journal club, which really kind of touched on the challenges of nursing handover. So from there, we've had a process with them to invite them to do a quality improvement collaborative process, whereby together we would use a graphic method to co-design their new nursing handover tool. So this interesting thing is with critical care nurses, they've got to be in the ward when you're doing quality improvement, and we've got to do it really, really quickly. So we had a 7-minute rule. I would come in super prepared, and then we would run through a couple of processes. And after 7 minutes, I would be finished and I would leave. They would also be able to watch their patients and carry on with their patient care while they were engaged. And so these are just a couple of steps that we went through over a period of a few weeks to co-design. This is our new nursing handover sheet, which is a prompt to kind of highlight the most important issues. But really what I want to, just for the purpose of today, was touch on is how we've managed to really highlight infection care in the handover sheet, which gives them specific IPC and AMS topics to, well, it's not really topics, it's just things to report on as they hand the baton over from one team to the next. And this has been implemented at the moment. There's been great uptake. Nurses are visual thinkers, and it's been a really interesting and exciting journey. So really just to wrap up in terms of limitations, I have only been looking at consultant-led morning ward rounds. And of course, this is not the only place where discussions happen. And of course, the effect of the Hawthorne effect was real, but I spent a lot of time in the setting. And so that was overcome eventually because I became a part of the furniture. But really just to end off, I'd like to more leave you with some thoughts around, opportunities to optimize team communication. And the first is to think about the impact of interprofessional and historical cultural barriers and how that influences your team communication. And then also, although IPC and AMS is for skilled specialties, all healthcare workers have a role in this. And how are we bringing those roles to the fore? We have to think about the fact that infection care discussions often become overshadowed by more important clinical priorities. And then we've got to think about how do we prioritize and structure routine communication in the ward round space, enabling everybody who has a contribution to make. And then also to think importantly about leadership and facilitation styles and the impact that has on communication. And so really just to end the talk by saying that communication is essentially important, but often it's so much a part of what we do that we don't really realize the implications of, the way that we speak to each other, the way that we include each other, and that has got a big impact on infection management and stewardship. And just to end my talk, I'd really just like to thank my supervisors, Professor Mendelsohn and Associate Professor Ismita Chirani, for their incredible support in this process, as well as Dr. Dina van der Berg. And thank you so much for your attention.
Thank you so much, Candice. Once again, thanks a lot for accepting our invitation and joining this session. It's always a pleasure to listen to the wonderful works that you're doing and to listen to all the findings that you're coming up. We have few questions for you. So I think one question is, how do you provide recommendations based on the data that you collect? So sociogram data that you are doing, how do you provide recommendation to the clinical team? So I know that you have had some success with improving practices in ward rounds based on the data that you have collected. So I think the participants would like to know, how do you convince the clinical teams based on this data that you collect?
That's a really good question. And so a very important part of my research methods and process is to have reflexive workshops with the teams. So 2 weeks ago, we had our second workshop with the ICU teams, where I basically feed back the results, not in a way for us just to kind of write them off, but to create a space for discussion. So the recommendations actually then get informed by their interpretations of whether A, they think it's important enough to do something about, and secondly, whether there is something that they'd like to change. And so it's been really interesting coming through this process, because it's not like me standing on the outside and saying, I think we need to do this, that, and the next thing. I'm not qualified to do that. And so all of what is potentially being changed through more quality improvement processes is what they identify as being important enough to act on. And so two recommendations or processes going forward, firstly is the thing about, should nurses and pharmacists and our dietitian have a slot in the morning ward round where they have expected contribution, they come prepared, and they feel like their contribution is valued. So it's not like an afterthought or, kind of getting caught off guard, because that's often what makes people feel really uncomfortable, is when they're not kind of sure if they're going to be asked or not, and they're not prepared. And so that was the one key thing that is coming out of it. And then the second is that potentially what the nurses are preparing in terms of their infection care discussions on their morning ward rounds, that might be brought into the ICU round. So they feel then that they are contributing something of importance. And it's not about tick boxing or trying to make people feel like they're included. It's genuine, because that is what nurses work with, and that is their contribution. Does that answer the question?
Yes, absolutely. Thank you. So I think the next question is, so you're doing sociograms, you're doing these qualitative, you're using qualitative methods to collect data. So from your experience, what do you think, what additional data were you able to collect because you're using sociograms as a tool?
So very interesting is that the sociograms have helped us to quantify counts of communication, which is really interesting, because we're starting to be able to identify relationships between, like leadership styles, the kind of impact of interruptions on the pattern of ward round communication. So one thing that's been really fascinating is what we've called the Mercury effect, and that is how there's the sudden interruption of focus in the group, and suddenly, there's maybe 3 different discussions that are happening of key things that are now exclusively happening from everybody else, and what the implication of that is on the actual pattern of the ward round. So we're seeing the implications on the basically on counts of communication, and this has been impactful for the team to see what this looks like, and to also think about the implications.
Right. I think many of the findings that you discussed also is sort of relatable to the situation in India, clinical practices in India. So just out of curiosity, do you have some recommendations based on what you have found in your studies, do you have some recommendations for clinical teams on how to improve team dynamics?
I mean, Verinder, yes, most definitely. I mean, we are definitely in the process of kind of synthesizing those into a space of what's doable. But I think from my scoping review, you know, the two main things that came out was structure, because structure enables prepared contribution. And, you know, we can apply that to many things, but we can also apply that to infection care discussions. I don't know how those would happen on your ward rounds, you know, and I've also been looking at this in our medical teams, and especially on post-intake ward rounds where it's chaos. You know, the patients are really sick. They're in a trauma unit that's jam-packed. You know, the registrars have different levels of experiences. They're not necessarily able to access all the patient information. So the way those rounds happen are very impacted on external factors. But and they do have a structure, but the infection care discussions can often fall away because, you know, they may be dealing with something a lot more important in that moment. But things like, you know, is the patient on antibiotics? You know, how's it going with the lines? You know, is the catheter in working order? And all of those kinds of things that don't seem important. Once one structures that into a little structured format that could take like a 20-second reference, I think that brings in that safety element to know that you've consistently touched on it for every patient in every ward. And then also the second thing that I sort of talk on a lot is the mandatory contribution of people who have got something to contribute, because in our space, it kind of relies on who wants to speak. Other than the consultants and the registrars, of course, they've got their roles, but the rest is very much dependent on whether the person's confident. I'm thinking of microbiologists, pharmacists' contribution, and our dietitians and nurses. So as soon as you make it mandatory, which is not the right word, and you structure it, that brings capacity, and it's empowering, and also it helps to tick the box like we've spoken about it. I don't know if that answers the question.
Yes. Thank you so much. I think that's it with the questions. Once again, thanks a lot for joining us. And I'm sure you have introduced a new methodology, a new area of antimicrobial stewardship to our participants. And I hope our participants make use of that. Thank you so much.
Thank you, Verinder.
We have one question for Dr. Hisham. I hope he's available in the call. Yes.
Available. You can go ahead.
So the question is from Mam and Paul. This question is, there are APIs available from many AI solutions like ChatGPT. Will hospitals embrace sharing their patient data for analyzing through these systems? This is a possible barrier I see in using AI technology.
So definitely data is very important in these days. So confidentiality is also a factor. So if you ask me, is it a barrier? For now, in the initial phases, it may be a barrier, but as you go on, this may help to ease things. So if you look at the healthcare system, the US or in some developed countries, it's all integrated in such a way that whichever hospital you go, you'll be able to see your records from the other hospital. So this is healthcare records. So if you look up data, so all these data could be pulled from the healthcare records. It's just sharing the electronic medical records with the interface or like ChatGPT softwares or things like that in such a way that it's available for them. So first thing is it is possible. So again, in the future, but how does it come is like, it depends upon multiple rules and regulations, which has to be put in place. It could either be through the government, or it could be through the hospital, which are collaborating with them. So initially it could be through a group of hospitals, or within one hospital group, which has multiple branches all over the country. And that could be a collaborative process where that data sharing could be done within that group. Second, it could be extended to hospitals which are willing to use this AI software in the region along with these hospitals. If the government takes its steps, then those regulations could be through the government and could be nationwide or statewide or region-wide as well. So integrating the electronic medical records to make it feasible, plus if you say the barrier for patient information, it's maintaining that confidentiality within that group of hospitals, which is the most important thing. I think it would be feasible only within a group, or if it has multiple rules and regulations within a region or the country put by law.
Thank you so much. So with that, we come to the end of the session, and we come to the end of FCPI Virtual ID Week. So we would like to thank all the participants who joined all the days, and I hope you all have been, you all are able to put into practice whatever you learned from all the amazing talks that we had over the week. Few pointers, few notes to the participants. You will be able to view all these talks in the FCPI website. We have requested the permission of speakers to share the slides with you. So whoever consents to that, those presentations will also be available to you. As we always mention, you are requested to fill out the feedback forms for each day that is sent to your email IDs. And only if you complete the feedback forms, we'll be able to provide you the certificate of participation that will be provided to participants only for a certain duration, that will be available, or that will be posted in our FCPI social media pages. So with that, we come to the end of the program. We hope you continue to support us in all our future endeavors. Do follow us on our social media pages to know more about upcoming events from FCPI. Thank you so much, and hope you all have a good day ahead. Thank you.